Welcome to ASA 2025 and this industry symposium titled Automated Anesthesia Delivery, the U.S. Experience. My name is J.W. Beard. I'm the Chief Medical Officer of GE Healthcare Patient Care Solutions, which includes anesthesia delivery. I'm an anesthesiologist by my training, and it's a real pleasure to be here. This is our agenda. And we're just going to do a quick introduction on end tidal control, what it is, and then we're going to hear a little bit about the experience with end tidal control at USC Keck and then also at University of Michigan. And our speakers here are Rosh and David. I'll give their full bios when I introduce them at their presentations. You'll notice here on the presentation slides, there is a QR code here for Slido. And please utilize that to submit Q&A at the end of our discussion today. So for those of you who are not familiar, I'm going to give you an overview here of end tidal control. So end tidal control is a software medical device that's available on the ASUS CS2 workstation. These arrows just highlight some of the features of the workstation that are not necessarily evident when you're in the room with the machine. It looks just like a regular ASUS CS2 machine. But what's unique with end tidal control is a couple additional enhancements. The electronic vaporizer, gas module, user interface, and gas mixer all come into play when this technology is being used during patient care. So if you look at a little bit at the user interface here and what the clinician is seeing while using end tidal control, this is a combination software and hardware application on the machine. There's a gas module you'll see that's there that's highlighted in red that's specific for end tidal control. On the user interface, it's pretty straightforward. If you've used a GE Healthcare workstation before, these are going to look like familiar keys to you. Those are highlighted there of some of the settings you're going to use for end tidal control for your oxygen and anesthetic. And also there's, with the gray arrow, there's a key press to start using a technology. Once end tidal control is enabled, the machine takes over your manual adjustments of fresh gas flow, oxygen, and anesthetic. It allows you to set the fresh gas flow that you want the patient to receive, the end tidal oxygen you want that patient to receive, the end tidal anesthetic you want that patient to receive, and then the machine makes the adjustments. The way I describe it to some of my colleagues is you think about end tidal control as if you're putting one of your trusted colleagues next to you at the head of the bed, and you tell that person, maintain fresh gas flow, oxygen, and anesthetic the entire case. Focus on nothing else than that and keep it at these target levels. That's what the software does for the clinician. Here's some of the evidence associated with the performance of the technology. So this is actually from last year, but I wanted to use this publication to highlight the accuracy that's associated with end tidal control. This was a study that was published in Anesthesia and Analgesia. That's the results from the trial done to achieve FDA approval of end tidal control. This is a multi-center study conducted in the United States, and this is about accuracy. So if we look at these two figures, on the left is volatile anesthetic accuracy, on the right is oxygen. So this bar indicates the mean percent of time that the end tidal anesthetic was within 5% of target. So we can see on that left figure that end tidal control was within 5% of target 98% of the time, compared to a manual administration where anesthetics can drift up and down over time based upon changes in gas flows, uptake in various compartments. That's something we've all experienced. Oxygen delivery accuracy, similar results there, mean percent of the time within 5% of the targets, and you can see that end tidal control higher there than the manual practice. 2025, here's some real-world results associated with end tidal control in clinical practice. This is published in the journal Anesthesiology. Comes out of University of Missouri. About 200 patients involved in this study, about half and half in the end tidal control versus the manual. This is looking at fresh gas flows and sevoflurane consumption. So we can see here on that left graph, the fresh gas flow with end tidal control went from 2.1 down to 1.1, about a 45% reduction in the mean fresh gas flow in that institution. And sevoflurane consumption decreased by a similar amount. This is measured in milliliters per hour, went from over 16 to around 9. So a similar reduction, about 45% reduction. And this is real-world experience with end tidal control. The medical system adopts it. They're trained. There are champions there locally who encourage the use of the technology, demonstrate or explain its benefits, and then we just see what happens when clinicians use it. And really incredible results there, published from University of Missouri. All right, before we get to our presentation, just an orientation to Slido. So if you go to this QR code, it's going to appear in these following slides. It's going to pull up the end tidal control Slido page. On the top left, there's a menu. If you touch that menu, it opens up, and there are hyperlinks to 5 publications in the last year on end tidal control. 3 of those are related to clinical results from individual studies. 2 of those are related to scoping reviews, which bring a fresh analysis of the last 5 to 10 years of end tidal control publication globally. So please take a look at that, and please take some time to submit Q&A for our discussion at the end. We'll have mics available at the end as well. All right, and it's now my pleasure to invite our first speaker today. Our first speaker is Dr. Arash Motammed. He is a clinical associate professor of anesthesiology and vice chair of clinical operations and medical director of the main OR anesthesia service at Keck School of Medicine of USC. He also serves as the medical director of sustainability for Keck Medicine of USC. His research and clinical efforts span perioperative quality improvement, organ transplantation, and geriatric cognitive health. In addition, since 2020, Dr. Motammed has led transformative initiatives to reduce the carbon footprint of operating rooms. Amongst other initiatives, Keck Hospital phased out desflurane nitrous oxide, as well as achieving significant reduction in waste of other volatile anesthetics. Please join me in welcoming Dr. Motammed.
Thank you for that introduction, and good afternoon, everyone. It's my honor to be here today and talking about Keck Medical Center's journey to end tidal control. What I really wanted to do with this talk today was divide it in half, and the first half of it is really going to focus on how do you greenlight a project like this at your institution? How do you get buy-in from the key stakeholders, C-suite folks, to say, yes, we're willing to invest? And then the second half of it is going to be, once you get that yes, how do you implement it in a successful way so that you can work on future endeavors with them? So we'll go over how the program was initiated, the strategies I used to try to get this approved, how we implemented and what our strategy was, and what did we do to make sure that it ends up being successful. So we're going to begin with how it all started. Now, there's a caveat to all of this. As you know, every institution is different. Leaders, people, we're all different human beings. So the example I'm giving you worked very well for us, and maybe it can serve as a roadmap for you. So in very simple terms, this is the org structure that we have. We have our senior vice president of health affairs that oversees everything. We have our chief clinical officer that's very involved with clinical activities, the CEO of the health system, and underneath him is the CEO of the Keck Hospital, which is the hospital I work at. And the 2 key folks involved with all of this is the chief of operations and chief of peri-op that report to him. And then on the other side, on the academic side, of course, the dean, chair of anesthesia, and the person basically that I report to. So how this all started, I had to go back in my emails to try to figure out a timeline, because I think that may also be helpful for you, is around July 2022, a member of GE team had reached out to our chief of operations with a white paper on end tidal control. And our chief of operations, John, had just started at Keck, and there was some big negotiations about MRI machines with GE, so there was that connection. And I was working with him and his team to try to figure out how we're going to remove nitrous oxide, so I had familiarity with him as well. So he sends me the paper and says, what do you think? I love new technology, so from my point of view, I said, let's try it. He was new to the organization, so he asked for my help to try to figure out how we're going to navigate this. So of course, from my side, the first thing is make sure the chair knows. I have a great working relationship with that chair. So, Dr. Holly Muir had the conversation. She said, do whatever you want to do. I approve. And I had a conversation with our chief of peri-op. And then this individual is more or less the type of person that would say, is this going to create problems for me or not? And if it's not going to create problems for me, I support it, do what you want. If it's going to create problems for me, I will stop it. So we made sure that the plan with doing a trial wouldn't impede the normal day-to-day OR functioning. So we decided to do a trial. Before seeing what the trial results were, we wanted to get a baseline data. So what I want you to also pay attention here, like about 7-8 months went by before we got the trial going. And some of that, I don't really think there were any obstacles. It was just priority of other things for all of us, and we could have pushed this up sooner had we known what the true benefits of entitled control program were. But it took a few months to do the initial data assessment. So GE came by, took 12 of our machines that we knew we use inhalational agents very frequently for, pulled all that data, and then a few months after that we did the actual trial. I wanted to wait until September because I didn't want, during July and August with new residents coming in and that, general chaos that, you're all probably familiar with, didn't want to do a trial during that time period. So we said, let's wait until September. GE brought 2 of their machines with the software on it. I selected about 6 of our anesthesiologists who I knew would be supportive to do the trial. And, if you were to ask me when did I think this program would be successful at Keck, I would have said a few hours into it, because the moment we got going, we started to get faculty kind of peeking in outside the window of the OR trying to figure out what's going on, nonstop, all day. And when I went to the cafeteria for lunch, 2 of them who typically tend to be resistors and would complain whenever you try to introduce something, were actually upset with me for not picking them to be part of the trial, which was very surprising. But that's sort of when I knew I think this is going to be successful for us. But we got the data from both, and similar to what JW just showed you with some of the other studies, our baseline was 2.2 liters a minute, which isn't surprising, and for the trial, we were able to drop it by 75%. So a pretty big change in reduction of sevoflurane use, which was a big deal. So went back to our chief of operations, John, said, hey, this was very successful. He said, well, what do you want to do with it? I want to expand this. I want to bring this to our ORs. Okay, so how do we do that? Well, first I got to talk with my chair again, make sure I have the chair's approval for it. I knew this part of it wouldn't really impact our chief of peri-op because it's just a software upgrade. We're not doing anything that's going to mess up the flow, so didn't even have the conversation with her. But when I was talking with John, our COO, he said, there's significant expense associated with this, so we got to bring in our CEO and have the conversation with him. And I said, okay, let's do that. And then a few days later, he said, you know what, I think we need to also bring in the other CEO of the health system. And since I don't know them so well, I'm going to have you do the pitch and do it in 5 minutes and try to impress them. And if you do, well, maybe we'll be successful. So fun exercise for me because I'd never done that before. And the main challenge was, how do you overcome the communication barrier? Because none of our C-suite are clinicians, so they're all admin background. And now here I am as a physician trying to figure out how to tell them what entitled control is, and that's not really easy to do. So I spend a lot of time trying to figure out how I'm going to do this. And I think the most successful people in the world are the ones who can really tell a good story and share their vision. So I try to figure out, what's the best angle I can use, and I do sustainability. So for me, even though there may be cost reduction in terms of, reduction in sevoflurane use, I really cared about the greenhouse gas impact. So started my story by talking about the healthcare's role in climate change. And by the way, most of these slides are the same slides I use. I just use different photos because now PowerPoint has better photos in its database. So talk about climate change. 8.5% of the greenhouse gas emissions in the US is from healthcare, and we're only second to agriculture. So it's a pretty big deal. And when you look at a hospital itself, it comes mostly from the ORs. We're a very surgery-heavy hospital, so it's our ORs that do most of it. And then anesthesiologists play a big role. But then I struggle to try to figure out how do I convey the impact of the anesthesiologist. And this is where some of the other studies that have been published that equate hour of anesthesia gas to miles driven is super impactful. So we live in LA. It's easy to tell someone, 1 hour of desflurane, may be equivalent to average combustion engine car driving from LA to San Francisco. So that's the moment you sort of get that aha from that CEO in terms of what that impact is. The CEOs want more cases in the OR, so now imagine every single hour that we're doing this, it's pretty impactful. And it equated to 2.5 times driving around Earth. And if you were to ask me when I thought I had them at that interview, it was with this slide. It was a different Earth photo, but that's when the CEO of our health system stopped me and kept asking questions because it's not something anyone really thinks about when you're talking about greenhouse gases in anesthesia. So then from there, I needed to tie that into end-tidal, and how do you talk about flow rate? My best example was washing hands, and we're still fresh out of COVID, so everyone still cared about this. And I said, you can fully turn the faucet on and wash your hands if your goal is to get the hand clean, or you can sort of do a little bit of flow, it still uses a fair amount of water, or you can do, what I would call the low flow system, which is use the soap, turn the water on, wash, turn off, and do that, so you use the least amount of water to do it. And essentially, this, in a way, is end-tidal control, except it's done in a very automated way, so it actually even makes it easier on the provider. I knew the next thing they were going to ask, well, is it safe, right? Because that's, they care about that. And this was very fortuitous for us that on the ASA website a few months before that, they actually put out the statement encouraging the use of low flow. So that worked out really well. And then after that, I knew they were going to say, well, you're one individual, you got a whole department. How do I know once I invest in this entire department is going to follow? So then I showed them my chair's letter of support, which I'd gotten before going to that meeting. Grateful that she wrote so much. All she needed was the last part that said, I'm supportive, let's do this. We'll make sure the entire department follows. The other part of it, which is, so what does the hospital care about? So hospitals care about data reporting. This part is a much bigger deal now than it was a couple of years ago. For us at the time, we were reporting our data to Practice Green Health on a mission, and also our university, which we ultimately report to, wanted that data as well. So it helped us pull that data and send that to them. Nowadays, there's even more need for it. If you want to get the Sustainable Healthcare Certification through Joint Commission, you need to be able to report emissions data. And at least in California, there's a Senate bill. I don't know if it will pass or not, but at least it helps tell you what direction California is going, is potentially having companies with high revenue report on Scope 1, Scope 2, Scope 3 emissions, and using anesthesia gases falls under Scope 1. And then the last part of my presentation was, of course, it's going to be dollars because that's what they care about in terms of cost savings. And GE was helpful in providing an estimate as to what that would be. From my side as a clinician, I said, I don't deal with the contracts. It's for you guys to figure out, but this is sort of my story is why I think this should work. And it was a very successful meeting, so much so that the CEO of the health system told the CEO, I don't even want you to worry about this. From your budget, I'm going to pay for this out of my own budget, which made my CEO very happy with me because now he had extra money that he thought he would have to kind of put for this project. And in some ways, it helped pave the way for me a few months later to actually get a stipend for the sustainability work. So it worked both ways. So we were very successful, but now I got all the big people in the hospital saying, okay, we paid for this, we're going to do it. You need to make sure it's successful. So that's where the implementation and the reporting comes into play. And I tried my best to do a fair amount of communication with the help of other colleagues, even before implementation, right? So September 2024 is when we first brought in when we did the upgrades. But as you can see, at every single faculty meeting, if I could, I brought this up. Now, generally, it's part of other topics that are being discussed, but specifically, we did address end-tidal control. And just being an academic place, there's a fair amount of conferences, symposiums, and such that we do. So every opportunity we had, we did that. And then there was also a fair amount of emails and other forms of communication that we did throughout. So it was very much a concerted effort from the start. And I'm not the only person that was involved. A photo of some of the other individuals on the next slide that were part of it. And these are some of the folks. So I'm going to highlight him because he's sitting right in front of me. Dr. Laney was also part of it, and Arun Nersessian, who couldn't join ASA this weekend, was very instrumental as well. And part of what we did also, along with my chair, was do OR rounds. So every now and again, also walk into the OR, see what they're doing, are they using it or not, and maybe casually or gently suggest, hey, what if you did this, and look what this does. And feedback was pretty positive. I did also want but I didn't have a chance to get a photo of Dr. Lowe, and I apologize, it's missing an E. But Dr. Harry Lowe was an anesthesiologist that practiced at USC, and he's the pioneer of low-flow anesthesia, and has a book on it and a lot of publications on doing low-flow anesthesia. So for us, again, it helped me tell the story and circle this back to who we are, what our identity was. We would always have attendings, even as a resident, I remember I trained there, that we would have attendings that would try to do low-flow and teach us, but was not done universally. And here was the opportunity to say, let's go back to, one of the early anesthesiologists in our group that was doing low flow, and let's start to do that together as a group. As we started to do it, we wanted to also show the data, and For us, the data started to come back starting December with Care Station Insight, so I don't have data beforehand, but as you can see, we started to reduce our maintenance flow rate from, and if you recall, we used to be in 2.1, 2.2s, slowly come down with time. I made the target of 1 liter a minute. It's a target I made up, and it's a moving target, so once we hit it, we're going to move it to a lower one, but it gives us a starting point and a way to move our group towards practice. And I also made the goal of wanting 80% utilization of end-tidal control, so, and as you can see, that's also had a nice upward curve on that graph as well. Some of the other data, naturally, as you do this, your cost per hour drops, your emission drops, and the slide on your right or on your left, the other one, sort of a different way of looking at the previous slides of seeing how the flow rates drop and how the emissions drop. And for us, and for me, especially being involved with the sustainable program at Keck, the emissions part really mattered. So we tried our best to showcase that to anyone who would listen, and I'll talk about this a little bit later, how to kind of circle this back and provide this feedback to the C-suite folks who were involved and who supported the project. One of the new things we started to do, and this is very much hot off the press, I got the data about a few weeks ago, is figuring out how we do provider attribution. So, we can pull the data from the GE machines that would say, OR1, use end-tidal control 80% of the time. Now, if you're looking at an aggregate data, it's hard for me to make that actionable aside from sort of general comment to everyone, hey, let's use end-tidal control. We work with our admin team that would pull the EMR data with the name of the providers and overlay that with the GE data to give me an understanding of who are the providers that are using it and who are the providers that are not using it. So as you can imagine, once I got this data last week, I had conversations with the folks on the red side. And the response has actually been, it's been interesting, it's been positive. So the response is, oh, I thought I use it, but if maybe I don't, so I'm just gonna be more mindful of using it. So it's not like they're resisting, so it's nice encouragement and nudging to try to get those numbers up. And I'm pretty confident in that we'll be able to bring our numbers higher through this type of reporting. The other part of it that was a big deal for us, and again, this is some of the stories that gets shared with our C-suite, is comparing us to other institutions. So this is the data from Practice Green Health. We report to them, so they share some of the data of similar types of institutions when it comes to emissions. And looking at sort of different anesthesia emissions per anesthesia case or per surgery hour. And on the column there, you see the metric tons of CO2 emission. And median is where other institutions are. The yellow is where Keck is. And a lot of this has to do, essentially, almost all is anesthesia related. And it's, we removed desflurane. We're a fully nitrous oxide-free institution, cylinders or central supply. The only exception is electrophysiology that uses it for ablation. And the end-tidal control program. So all of these combined have really helped drop us, and this is what our C-suite folks love to see. We also started to build an ecosystem around the work that we do, and again, I took the storyline and the angle of sustainability. So we have established our sustainability steering committee. We have KUSHI, which is an organization I always love to plug when I get the opportunity. It's the entity for us that works, it's multidisciplinary, multi-campus, multi-institution, trying to put together whatever sort of knowledge and information we have on the projects that we do that are sustainability related and sharing it with other institutions. Monthly basis, we have our OR sustainability team, and every single month they see that same graphs that you saw with the end-tidal control usage. And that's the group that sometimes gives these recommendations of what are some of the things we can do to try to help improve it. And we partner with other groups within USC and outside of USC to talk about our experiences and how we can improve the numbers. And then I'm going to circle back basically with how we started, which is the group that greenlit the project. I think as clinicians, very frequently we get frustrated with our senior leadership and admin with some of the things they do or don't do. But I think it's also important to let them know when they do something that we think is really good and encourage more of that. So the way you do that is just letting them know how things are going. I have the opportunity to have, on a regular cadence one-on-ones with all of those individuals. So every single time, even if it's a one-liner, it comes up. And now they sometimes ask me, how's that program going? So yes, it's going well. Let me share some data with you. I don't want to inundate you with information, but every now and again, we'll sort of send some information. a lot of the data and reporting that you saw has been sent to them. And then every now and again, probably about twice a year, I do ground rounds at our department or other departments within our health system. I invite them, and it's surprising they show up. I was blown away when you get the SVP of Health showing up to some grand rounds with Department of Surgery or Department of Anesthesia talking about sustainability and talking about the projects that we do. But this is how they get to see the impact of the decision they made 2 years ago after a quick sales pitch. And I'm not a good salesperson, but somehow they bought it, and now here you are, and let's see the fruit of that labor. And then the last thing I'm going to basically go over is more promotion of the work wherever we are in our own institution. So I made friends with our marketing folks. So there's a lot of newsletters. They love anything we can give them to send out. So just a few snippets of some of the stuff they've done over the last year and in sort of various channels that they have, talking about some of the work that's been done with, a reduction of greenhouse gases, carbon footprint, and using the Entitled program to minimize the sevoflurane waste. So overall, I think it's been incredibly interesting and unique experience for me. It was the first time I was kind of going through this type of a project. And, of course, there's questions and doubts on whether it's going to be successful or not. But very proud of our group and the department, how they approached it. And overall, as a system, very supportive of this. And, from my point of view, our hope and goal is we upgrade our other ORs or build new ORs and get our new anesthesia machines that will have Entitled control with all of them. So that concludes my presentation. I thank you all for listening to me.
Thank you, Arash. So gone are the days when the physician can walk into an office and purchase or advocate for the purchase of something that he or she wants without needing to attend to the needs of various stakeholder groups and to come with evidence. Also really appreciate the approach that you've taken with continuous quality improvement and providing feedback to your clinicians, and then sharing the results of the investment to your administrative colleagues and demonstrating the impact they've had. So really nicely done. All right, so our next speaker is Dr. David Hovord. He's a clinical assistant professor of anesthesiology specializing in liver transplant at University of Michigan. He's the director of both multi-specialty anesthesia and the equipment and supply program and leads the Green Anesthesia Initiative at Michigan Medicine. Dr. Hovord is passionate about using technology to help improve patient safety in anesthesia and is a member of the APSF Committee on Technology and the Patient Safety Committee of University of Michigan. He gained his medical degrees from the Universities of Oxford and Cambridge in the UK. He's been using Entitled control in clinical practice for over 2 years. Please welcome Dr. Hovord.
Thanks, JW, and thanks everyone for coming along to listen. I just want to spend a bit of time talking about our experience implementing Entitled control at the University of Michigan, what that kind of looked like. And we've had it now, I think, for 3 or 4 years in clinical practice, so we've got quite a lot of data, which we'd also like to share with you, some of which has been published, some of which is preprint. So I am, if it wasn't already obvious, a consultant for GE Healthcare, and I'm a member of the Krinsky Co. Health Influencer Network. So yeah, we have two main studies that I'd like to spend a bit of time on, and talk a little bit about why and how we implemented Entitled control at Michigan Medicine. And then I also want to just get into the nitty-gritty of what one particular case looks like when you do it with Entitled control and without, because I think that is really instructive as a provider being in the room as to what the difference really is. Just a little bit of background. The U of M is a big hospital. We now, I think as of next month, we'll have over 170 anesthetizing locations. And in 2 or 3 months, every single one of those anesthesia machines in those locations will have Entitled control. So we have a lot of machines doing a lot of cases. In a lot of different types of site as well. We have some ASCs for outpatient stuff, and 3 large academic hospitals, soon to be 4. 500 providers. This is a big department. Rolling anything out takes a lot of effort. We have almost 90 residents, 300 CRNAs, 100 full-time equivalent faculty, and the new hospital opens next month. Just briefly, why entitled control? Well, our anesthesia machines were coming up for replacement around the time of COVID, and you might be able to tell, but I did most of my training in the UK, where entitled control is pretty much ubiquitous now, and was in the hospital that I worked at before I came to the US in 2011. So I had a previous experience with it. And we had the same anesthesia machines when I came to Michigan, and I remember kind of searching through all the menus trying to find where it was, and it didn't exist, and no one would really talk about it. And soon we realized that it was because the FDA wanted new trials and new studies. And kudos for GE for going through that process. I think it was expensive and took a huge amount of resources to do. But I think it was really important to get this technology rolled out into the US. When we were trying to present to the Capital Committee, we have a similar process as Arash to try and get new equipment into the hospital. But the CMO asked, these new anesthesia machines, they seem very similar to the ones that you've got at the moment, except they're just slightly newer. What will they do to improve patient safety? And I was really glad about that question, because it really, I think, codified what we are trying to do as clinicians and as anesthesiologists in the OR every day. And really, for me, entitled control is about patient safety. It automates one critical task. It's not possible to get a hypoxemic gas mixture if entitled control is turned on. The entitled SIVO concentration won't drift around. It will be precise. It will be exactly where you set it. If you set it at the wrong target, it will achieve that target. But, if you are overloaded in the OR, as often happens, especially we see when we're training junior residents, there's a lot of things to think about. And this is one critical task that automates. And it automates it in a way that's more precise than a human can do, checking multiple times a second that you're reaching the target. And then low flows. Low flows, we've heard a lot about the sustainability case for entitled control. And people have been talking about low flows since I started in anesthesia back in 2006 in England, and no one ever really does it in a way that is sustainable across a whole institution. I think if you tried to say to everyone, right, if you went to your tertiary hospital and said, I want you all to use flows tomorrow at 0.5 liters per minute, I think you'd probably get a lot of hypoxemia and a lot of awareness happening if you didn't do any other training and any other study around it. And even if you managed to have an impact, that impact would fairly quickly drift off, and you'd have to be continuously re-educating, going around trying to get people to put their low flows on. There are also economic and sustainability kind of aspects to low flow. If you cut your flows in half, you're going to use half as much SIVO. And one of the things that we found predicted during our green anesthesia initiative at U of M was that as we moved away from isoflurane and nitrous as the primary anesthetic towards sevoflurane, that would probably double the cost of our gas cost to about $800,000 a year. If we could halve our flows, that would pretty much take us back to where we started. And actually, that was exactly what happened during our whole process, which took about 3 years. We moved away from nitrous oxide, eliminated it as a familiar story. I'm sure you've heard it a lot of times before. Moved to sevoflurane at low flows. The costs of the gas were exactly the same as when we started using nitrous oxide, except that we'd managed to reduce our greenhouse gas emission by 90%, which was about 7,000 metric tons of CO2 a year. It's about 250,000 miles driven every year. And this technology, I think, was crucial in allowing us to do that. So here's just some charts. U of M is known for its love of data, so it would seem a shame for me not to share some graphs. But what I wanted to do here was go back to, I think it's 2018, and the line on the bottom shows average flows per minute in one OR. This is OR 17, it's the liver transplant OR. It's where I spend a lot of my time, which is why I picked it. And there's only one thing really that had any impact on the top line, which was case volume. And you might be able to make out the date there, but it's the first quarter of 2020. And so it took a pandemic to have any impact on any of these lines on this chart. and it did have absolutely no impact on flows. When the pandemic ended, we started our Green Anesthesia initiative in about 2021, and we said to people, why don't you think about using less gas? And as you can tell, no one did anything about it. We roll forward. We had the very first end tidal control machine in OR 17 placed, and you can see on the chart very clearly. So despite lots of talking about it, 5 years worth of data, you put the end tidal control machine in, and flows dropped. Now, this is just kind of raw data. It wasn't like processed at all, so it's not. There was no special training that went into the OR. It was just a machine put in there, see what happens. And then you can see at some point, our clinical engineering department took the machine away for preventive maintenance and put it somewhere else, and flows went straight back up again. So this technology definitely has an impact. It's kind of instantaneous. You can see it. And more than that, when the machine disappeared, the whole of the liver transplant team came back to me and said, "Where's that machine gone? We really want it back." I think that was really instructive to me as to how impactful end tidal control can be. So, as part of our rollout, we rolled this out over a number of sites, and one of the sites we rolled it out into was a ASC, or an ambulatory surgery centre in Brighton, which has 6 ORs. And what we really did there was, on one day in the middle of July, we just upgraded all their machines to make them end tidal control capable. Everyone had already done the training module, but probably about 6 months before. And we really didn't do anything else. We said, let's just see what happens. Will people use it? Will the low flows, will flows drop? And so we collected 6 months worth of data, and we did this through the MPOG program, which Michigan is a lead. And we got some really kind of interesting results, which hopefully you can see. There were about 1,000 cases. Overall usage of end tidal control through the whole 6 months was 28%. Started at 20 and was at 50 at the end of the 6 months. When it was used, fresh gas flow decreased by about 1 litre a minute, which caused a CO2 equivalent decrease of about 1.14 kilograms per hour. That's just a number, it doesn't mean very much. But if you're halving, it's basically halving the gas flow. There was no clinically meaningful difference in MAC. So if we looked at the average MAC over the cases, there was no basic difference. So it wasn't that reduction in CO2e was done because people were using a lower level of sevoflurane. It was just less sevoflurane used to achieve the same MAC. And this is really instructive, right? What I think we really struggle with as clinicians, and specifically clinicians that are looking to use technology and bring in technology to change behavior, is often the real-world claims that are made about equipment don't match up when you throw it into a situation to say, hey, look, is this going to work or not? And it was fascinating that what we saw here was a really quite rapid adoption by providers, and that when it was used, it did exactly what you would expect it to do. This is just a graph to look at the end tidal control utilization over time. As you can see, July is kind of a part month. But over the study period between July and January 2024, it starts at 20 and starts to go up. This is just one of my internal QI dashboards that we keep looking at end tidal control usage. This is at our university hospital, and here the rollout was a bit slower. We have 120 machines at the university hospital. We were replacing them at about 35 a year. And you can see as time went on, 2023, 2024, the green box is the box of end tidal control cases used out of all of the general anesthetic cases done at the Michigan Medicine. So again, take-up is slow to start with. 20% of people will see a button and press it and see what happens. Most other people need a bit more time to figure out what the button does and need a bit of education. And I think there's tons of introducing change literature that will say exactly this thing, that if you have something that's good, it doesn't get implemented immediately. But you can see now we're running at about 70% usage. And we want to get as close to 100 as possible. So then we did a larger study over, I think, about a year, looked at about 15,000 cases. This was across the whole institution, excluding the the pediatric hospital. There was a mix of the ASCs and the tertiary centres. It looked at the full suite of anaesthesia providers, resident CRNAs. We included all types of airway device. And through the life of the study, end-tidal control usage was about 50%, which is actually nice for us because it allowed us to compare and contrast the factors that went into the use of end-tidal control. What we found was that the provider in the room was almost the key differentiator between whether or not it was turned on or not. Now that might seem obvious, but you might have thought that maybe people weren't turning it on in like otolaryngology cases, or there were certain types of cases that people didn't want to use it on. But actually, no, it's just the provider. And if the provider is educated and knows what it does, then they turn it on. If they don't know what it is, and they're the sort of person that doesn't just press random buttons to see what happens, then it stays off. When it was used, flows reduced by about 1 litre a minute, 41%. I think that number seems to come up a lot. This is real-world data. There was no study protocol for this. We just threw the machines out there to see what would happen. A few more graphs. This looks at the percentage of time, and we're looking specifically at maintenance, which is from, we defined it as from when the airway goes in to when the provider clicks emergence on the EMR. And when it's switched on, how much of the case is it switched on for? So what you can see is that when people turn it on, it stays on for pretty much the whole case. There is a bit of a lag in when people turn it on, so they don't turn it on immediately, and we'll come to that in a bit. This looks at what happens when end-tidal control is switched on. So here you can see that the fresh gas flow on the left falls. SIVO consumption per hour also falls. I think that original study you mentioned, JW, said about 9 mils an hour. That's pretty much, we're seeing 8 on average. And then CO2 equivalents will also reduce along with that. Now, I'm a big proponent of using the sort of the nudge philosophy to help drive change. And one of the things we thought very carefully about was where to set the defaults for this technology up. So when people turn on end-tidal control, it defaults immediately to 0.5 per minute. And what that means is that if people want to go above 0.5, they have to turn it up. They have to do an active thing to make the low flows higher. And by and large, people don't do that. And that's, I think, just human nature. Now, this chart is really nice. When you first look at it, it kind of makes your eyes go a bit funny. The grey bars are the percentage of cases with end-tidal control turned on. So what we're doing is we're progressing through maintenance here as a percentage. So on the scale on the x-axis is the percent of the case that's done. So whether it's a short case or a long case, it looks at how long did it take people to turn end-tidal control on. You can see there's a bit of a lag at the start. So some people will secure the airway and hit the button straight away. That's ideal. Other people will just kind of secure the airway and leave the flows at 8 litres a minute for 20 minutes. That's, not ideal. The purple line here is the flow, average flow when it's used without end-tidal control. And the green line is the line with end-tidal control. And you can see at every stage of the case, cases done with end-tidal control turn on have lower flows, and as a result, consume less sevoflurane. So just kind of zooming in a bit now, that's kind of the broad look at what this technology does when you put it into a big healthcare system and let it work. This is a liver transplant. I picked this because it's a nice long case, and I think it's quite instructive. These are the kind of cases where we love having end-tidal control. Really busy, lots going on, just one less thing to think about. The yellow line on the bottom there is the sevoflurane concentration. The black line of flows per minute. And the blue line is the FiO2. So one thing you might wonder is why do the flows go up to 100% in the middle of the case? That's because we don't, although we used to have piped nitrous oxide in our ORs, we didn't have piped air, which means that you have to have air tanks on the back of the machine. Which is why when people came to ask to ask whether when we eliminated our nitrous pipeline, whether we'd be able to survive on nitrous tanks, we were able to say, well, we survived with air tanks for the last 30 years. And when they built the hospital, they put a nitrous pipeline in, but not an air pipeline, which is fascinating to me. And in 2025 is completely the wrong way around. So what happened in the middle of the case was the air tank ran out, and so the FiO2 goes up to 100% while someone goes to get a new one. But what you can see here is that the flows stay pretty consistently at 2 litres per minute for the whole case. The sevoflurane concentration wanders up and down. This is the same case with end-tidal control, another liver transplant. You can see again flows high at the start of the case, the black line. But then they drop down to 0.5, and they just stay there through the case pretty much. There's the odd blip where adjustments are made to sevoflurane concentrations, so the software responds by increasing flows shortly to make the change. The sevoflurane line looks a lot straighter, and when you zoom in to the first hour, I think this is really instructive. The first hour of a liver transplant's really busy. You're doing the echo, you're placing lines, doing all the things. On the right-hand side, as you look at the screen, is the sevoflurane concentration in the first hour of the liver transplant. And it just wanders up and down. Now, it goes up from 1.5, and obviously someone sees that, the patient gets hypotensive, so they turn the flow down, they carry on doing what they're doing. It drops to 0.8, and then someone sees that and says, hang on, that's a bit low, you turn it back up again. When you use end-tidal control, it goes to 1.1 and stays there. And it really is instructive, because clearly, whoever's doing this case probably wants a sevoflurane around about 1.1, and for the first hour, the range is huge. And it's just not precise, it's not accurate. No patient was harmed, but it's not accurate, and it's not as precise as it could be. And you have to think a lot more about your sevoflurane concentration than you do with end-tidal control switched on. Just a word here about the next steps really for us. We've talked about the economic benefits by low flows, but there is also a CPT code attached. Currently, it's an experimental CPT code for end-tidal control. We were able to document the machine mode in the EMR automatically. So in one of these flow sheets, the ASIS machine puts out about, 120 parameters every 5 minutes or every minute. One of them is the mode the machine is in. So that is in our EMR, and that's what has enabled us to do all the studies on this, because we can tell what mode the machine's in. It turns out the billing department is also able to lift that information for reimbursement. And we have, I think, at Michigan benefited from that. And it may or may not be possible in your institution, but for sure, the more people that use these CPT codes to track usage builds the case for reimbursement, and also helps track its usage. And we need to optimize it. We need to get that 70% to 100%. We need to reduce the time spent in maintenance where end-tidal control just isn't used. We already kind of alluded to this, but if you turn the flows up at the start of the case to 15 litres and leave them on for 20 minutes, it doesn't really matter what you do for the rest of the case. The damage is done. I mean, you've just blown through a whole bottle of sevoflurane. You can turn end-tidal control on, but unless you get to that real goal where you can get that end-tidal control switched on nice and early. And we did, in one of our studies, come up with a really nice way of tracking this, which was the mid-case delta. It's a little kind of arcane, but if you look at the flow in the middle of the case, if you've got end-tidal control switched on, it will be 0.5 per litre, or whatever you have it switched to. If you look at the average flow for the case, the closer that is to 0.5, the better job you've done. If you get that switched on immediately down to 0.5, then your mid-case and average case flow should be the same, and that is where you've optimized end-tidal control. So that's kind of what we're using to try and optimize. We're also doing a mixed method study looking at attitudes to end-tidal control. Trying to just understand why people don't use it. Why don't you turn it on? Is it just forgot, or is there something about it that you don't like? And I think it's instructive for the implementation of automation in general. We're all waiting for the AI revolution to hit, yet there is resistance to automation of simple tasks. So this is definitely a stepping stone. In the same way as, autonomous driving is, say the goal for car companies. There are steps that you'd need to go through first, like lane keep technology, automatic braking, that kind of thing. Automation that makes things safer in cars. And I think that, understanding how entitled control is seen in ORs is going to be really instructive for figuring out how we can continue to automate and make care safer. So I think in conclusion, it's pretty clear that entitled control makes care safer, more precise. It reduces fresh gas flow. It does exactly what it says it should. And when you take it away, providers really miss it. And I think for me, that's the most instructive part of the whole thing. Again, thank you so much, guys, for coming to listen. And I'm going to take questions.
Thanks, David. Really incredible work that's happening at University of Michigan, both with sustainability and then utilization of this technology and creating the real-world evidence that I think gives other institutions the confidence of the types of results they may get. It's not a prospective randomized clinical trial that's led to results. It's University of Michigan putting us in the operating room, training people, and then we observe how they utilize it. All right, so for the Q&A here, reminder, you can go to Slido. We've got several questions that have come into Slido. And I'm just going to start with one of my own here. So at neither one of your institutions is utilization of end-tidal control 100%. Why is it not used 100%? Like, you pointed to some of the reasons, David, some provider preference, but what do you guys, are there perceived barriers to it? Is it individual preference from your experience thus far? What do you think would get it closer to 100%?
Is this, I think it's on. Yeah, so I think it's a great question, and we see this not with just end-tidal control, but every single technology we bring in. Last week we trialed some hemodynamic monitor, and one of the rooms that we wanted to trial it in, one of the providers said, well, I'm not going to use it. So some people just don't want to use new things. So I think there is that. Largely, I think that there aren't any real technical or utility barriers to end-tidal control. It's very, very straightforward to use. It does exactly what you should expect it to do. So I think we're just dealing with people kind of forgetting in a way. And one of the things that I wish that you could have and one of the things that we're going to implement in our EMR is that as soon as they hit airway, we're going to put a flag up saying, is end-tidal control switched on? Just little reminders, little hints, little nudges.
Yep.
Most people, there's no kind of resistance to the actual technology itself. When you speak to people, they understand how it works. They get that it's better. Sometimes they just kind of forget. And I think, that's probably the slightly unsatisfying answer.
No, it's dealing with clinical behaviors and practice patterns and introducing new technology. It takes some time. It takes some effort. Arash, how about at USC?
I think the biggest challenge we have is the same. I forgot, and it's because we have a lot of rotating residents, that may be in our main ORs for a few weeks and then may not come back for a few months. We also don't have entitled control in all of our sites. So, you could be someone who's, working in one place that doesn't have it today, and then tomorrow, again, you're in our main hospital where we have it. So I think it's, when we ask them why you don't use it, it's generally, oh yeah, I forgot, and then they click it.
Yep. Thank you. A couple safety-related questions that came through the Slido Q&A. The first one, what happens in the case of a gas sensor failure? Remember, this is a gas sensor that is end-tidal control specific. If there is a failure or one of the checks fails, the system reverts to just manual fresh gas flow. So it alerts the provider and then switches over to a manual administration process. How fast can you react to an intraoperative emergency, hand ventilation, 100% oxygen, et cetera? You would switch out of end-tidal control, manage your flows appropriately, your FiO2 appropriately, and take over manual ventilation as you would in a typical anesthetic. A couple questions here for you guys, especially at academic medical centers. What's the impact of automating the delivery of an anesthetic and oxygen in a teaching institution for your trainees? How do you guys manage that in terms of getting people ready for independent practice?
Yeah, I mean, it shows you what it's doing. So in some ways, it actually makes it easier for people to understand the concept behind low-flow anesthesia. One of the things that we struggle with is trying to help people understand that, you know, you've got this system, you're putting gases into it and gas is being taken out of it, and you have to balance the two. And the lower flows you do that, the harder that gets to do. But you can actually use this device to, you know, to help educate. And I think we've faced this question with a number of different technologies over the years, ultrasound being one of them. I remember being told, training that I had to learn how to do central lines blind because I wouldn't always have an ultrasound machine. Turned out that wasn't true. There's ultrasound everywhere that you want to look. And so I think that we do face this with every single time that we roll out a new technology, which is that, you know, people say, you know, how are you going to cope when you don't have it? Well, we can see how people cope when they don't have the technology. They just go back and do it without low flow. I mean, we've proven that at U of M before. So low flow anesthesia has never been taught well. It's never been taught to the standard where people are comfortable to do it on a daily basis, and it's always been a kind of an added optional extra. So I don't think that just because you've rolled out low flow end-tidal control that suddenly you're going to have a whole cohort of residents that are unable to do low flow anesthesia.
Yeah. Arash, how about at USC? I don't recall that being raised as like a concern or objection from during the purchasing process per se. There wasn't a concern about trainees' skill sets, or maybe I missed it.
It never truly came up as a big concern, although it's come up with some of the other initiatives we've had. And, you know, he used the example of ultrasound. I use the example of the video laryngoscopes. It's the same thing. And I think the thing with end-tidal control, if you want it, although I don't recommend it, you can easily switch out and do it without end-tidal control if you want to see what happens or learn that way. But it's, you know, at some point you have a technology that does the job better and frees up your time. So from my point of view, there's really no point in emphasizing you got to do it the older way, which was less accurate, less imprecise.
Yep. Thanks to both of you. Thank you, everyone, for attending. For those questions we did not get to, we're going to be hanging around here. If anyone wants to come ask a question up at the front, please do. We appreciate your time, and we're available for any questions. Enjoy the rest of ASA.